My name is Diagnoses with the Community Technical Assistance Center at NYU's McSilver Institute. And again, want to welcome you to Considerations for Youth with Mental Health and Intellectual and Developmental Disabilities Diagnoses with Dr. Susanna Ayodora. Dr. Ayodora is a licensed clinical psychologist and associate professor of pediatrics and public health sciences at the University of Rochester Medical Center. She is the director of the Strong Center for Developmental Disabilities, a federally mandated university center for excellence in developmental disabilities. Her research and clinical work focuses on programs, services, and advocacy for people with intellectual and developmental disabilities across the life course. Now, before I turn it over, just to get started, on the following slide, I do want to highlight that we do have a quick note from CTAC. The content shared is for informational purposes, not advice, and should not be relied upon as a course of intervention or as a substitute for your own professional judgment. We encourage you to refer back to your agency's policies and procedures, as well as relevant regulations. And with that, I'm now going to turn it over to Dr. Ayodora to get us started.
Great, thank you so much. It's nice to be here with all of you. I'm Susanna Ayodora, and I have worked with people with intellectual and developmental disabilities for the past 25 years. Like Diana said, we have a federally mandated Center for Excellence in Developmental Disabilities in Rochester, New York, and I want to recognize our sister Centers for Excellence in the Bronx and Westchester. And we have a statewide network supporting people with intellectual and developmental disabilities. And it's a really important federally mandated program and resource that everyone should know about. So I do like to mention it, and I'd be happy to share more about the purposes of that network later on if folks are interested. So it would be helpful for me to know a little bit about all of you. I appreciate all the introductions in the chat. Thank you. We have a quick poll just so that as I get started, you can share a little bit about to what extent you have worked with people and youth who are autistic or have an intellectual and developmental disability diagnosis. That would be helpful for me to know. So thank you for completing that poll as I move on for some of our introductory slides. So I don't have any disclosures to report. And I do want to thank Dr. Brenna Kavanaugh and Dr. Leona Oakes. They are clinical psychologists who do work in the autism and intellectual and developmental disability space as well. They are wonderful collaborators of mine over the years, and some of the intervention content that you will be hearing about today has been adapted from our extensive work, including statewide support to mental health providers and crisis providers through the Office of Mental Health and Office for People with Developmental Disabilities. So we've had longstanding collaborations with these state systems, and I do want to make sure that they're recognized for their work. Oh, wow. Okay, our poll results are in quick. So it seems that about half of you work with people with IDD quite often, a third of you sometimes, and then about 13% rarely or never. Okay, great. So hopefully then I will try to maybe do a little bit more interaction with this presentation as well, so that if you have successful strategies or experiences that you'd like to contribute to the conversation today, I'm sure all of us would be very happy to learn from your shared expertise as well. Here are our objectives for today. These will be replicated on your continuing education forms. We want to talk a little bit about the specific symptom presentations of common mental health conditions in youth with intellectual and developmental disabilities. I will now abbreviate to IDD for this term. We'll talk a bit about mental health risk and protective factors in this population, and then think through what are the adaptations and considerations for assessment and intervention in this population. Anytime I talk about autism, anytime I talk about the disability space, I want to start with a discussion on neurodiversity. I think especially right now in our history and current context, it's important to recognize the disability movement as a component of our history of social justice and civil rights. So the disability civil rights movement has been very active and steady, but quite honestly, has been kind of on a little bit of a delay from other civil rights movements. And as such, I feel like it's not as well recognized within the community. And so I do always want to make sure that when we are discussing these particular concepts, that we recognize that people with disabilities do not have access to our full community in the way that they should, just like many other marginalized groups do not, and that I think collectively as providers, we're all responsible for doing what we can to advance the civil rights movement for people with disabilities forward. In that context, a discussion of neurodiversity is always helpful. Feel free to put in the chat. I would love to hear from folks about whether this is a familiar term at all to you. I think that there's no one definition for neurodiversity. So if you would like to share if you're familiar with this term, or yes, very familiar, or maybe even a couple words or a phrase about like, what does neurodiversity mean to you? I would love to read a couple of those responses out so that we have multiple perspectives represented here on neurodiversity. So thank you, Andrea, for saying that you're very familiar. Does anyone have any word? Yeah, Sarah says neurodiversity represents that your brain thinks differently. Everyone thinks and operates differently, that you might need support. A lot of emphasis on the word difference, which I think people use to kind of minimize the word disability or impairment and focus more on a strengths-focused approach. My personal community more typically uses neurodivergent. Yes, that's a really nice distinction too. I think that neurodiversity is probably the broader concept to share, that everyone has a specific set of preferences and skills and areas of growth that are needed, and we all fall on a neurodiversity continuum. And then there are those who might kind of cross over a line where they consider themselves to be neurodivergent. And when we talk about the autistic community, that absolutely often overlaps with the neurodivergent phrase. A lot of folks with intellectual disability or other developmental disabilities, or even ADHD and such, would also consider themselves neurodivergent. So I really appreciate that clarification. And I will read from Irene. Neurodiversity is about accepting that everyone's brain thinks differently. Disability is part of existing differences and it's neutral, just things that happen in the world. Yeah, absolutely. Disability is part of the natural human experience and doesn't need to be thought of as something separate from what we all either experience now or could experience one day. I'm going to show this picture really quickly and just give you 5 seconds to get an impression of this picture of a wheelchair in front of a set of stairs. Okay. And the problem that we might ask ourselves here is, what is the issue with this picture and what is the issue for this person? Is it that the person is sitting in a wheelchair and doesn't have a way to get up? Or is the issue that the stairs are present and there isn't an alternative way for that person to get where they need to go? A lot of people are saying stairs. Yes, absolutely. And this is like an oversimplification of a distinction between the medical model of disability and the social model of disability. Again, I can tell that people are probably familiar somewhat with this distinction, but I do think it's important to always share when we talk about diagnostic categories, to understand that any diagnosis, especially one that's based on kind of behavioral phenotype as opposed to something medical or genetic that we can identify, has to be influenced by our society's perspective of where that line is between what is difference and what is not. And so in the medical model of disability, there is an overemphasis on the person in some way being the problem, right? Like, I'm an individual who doesn't have the skills. I don't have the physical ability. I don't have the cognitive capacity. I have impairments or deficits, right? All of these terms are very negatively valenced, and they very much kind of assign responsibility for a person's ability or inability to navigate the world to that person and their individual characteristics. And as it says here, impairments and chronic illness pose real difficulties, but they are not always the main problems. Now, I work in a medical center. I am surrounded by the medical model of disability all the time, and I understand that a medical model has its place, but I think that diagnostic categories and distinctions need to also be balanced by something that we call the social model of disability. And in the social model of disability, the barrier is not necessarily the person. There are societal barriers that prevent the person from being able to be included to their full extent. And that means that we don't have accessible ramps, for example, or a chairlift for that person to go up the stairs. That the language that we use might be prohibitive for some people to interact with us or to be able to navigate the way that we lay out the landscape of the world. We have a lot of signs that are text-based, and so people who don't read English might experience those as barriers to inclusion. And then very importantly, there are a lot of attitudinal barriers that might influence whether a person is fully included, particularly a person with a disability. How we feel about people with disabilities, what we think they're capable of, what we assume they're not capable of, whether we're engaging in discriminatory practices, or even whether we have the training to welcome people with disabilities into the spaces where we operate, right? And so always engaging in self-reflection around natural prejudice or ableism is always an important activity, I think, for everybody, because we're brought up by society. And so it's hard to completely avoid those stereotypes and contexts. But by reflecting on them and engaging with them and pushing back on them, we can collectively advance anti-ableist strategies. And so again, there's a lot of conversation in the autistic community, especially about social model versus medical model of disability. And a lot of autistic people will say that the medical model has a place, right? For the way that our society operates right now, we need diagnostic categories, quite frankly, oftentimes, to be able to open doors to services that are necessary for folks, right? And so saying that, like, well, autism is all a social model of disability, and so there should be no autism label. A lot of autistic people will disagree with that because they feel both a sense of pride around their autistic identity, a sense of connection with their autistic peers, and then the idea that their label of autism might be needed for them to access needed supports. So I don't mean to present this to say like either of these options is the one, but rather as a balance to help us shape our overall understanding of the world and how barriers might impede or facilitate disabled people being able to be fully included in their communities of choice. Okay, so it all comes down to, right, what is the issue, the person or an inaccessible world? And in folks with intellectual and developmental disabilities, or IDD, there are often a lot of barriers on the mental health side that I'm sure if you're working with disabled folks, you have experienced yourself, right? And so we know that providers, we don't naturally get necessarily a lot of training in how to adapt interventions, how to adapt communication styles, how to adapt assessments, how to adapt mental health services for disabled people. And there often aren't good kind of communities of practice to help support that over time. So that is what we're going to focus on today. And again, because we do have experienced people in this group, which is really nice to see, a little bit unexpected for me, but that's exciting. I would love to hear in the chat as we go, anything you have to highlight about strategies you use or experiences you've had or skills that you have that can kind of highlight the content today. I am starting just with a bit of an overview of intellectual and developmental disabilities, which present usually at birth. They do have to emerge in the first 18 years to be considered a developmental disability. They can affect the trajectory in very variable ways of a person's physical, intellectual, or emotional development. And intellectual disabilities usually include both delays in intellectual functioning, so reasoning skills, learning skills, problem-solving skills, normally as evidenced through an IQ test, as well as adaptive behavior, so the way that we get along and figure out how to operate in day-to-day life, which includes social skills, communication skills, and life skills. And especially, I think that there can be a tendency to always conflate that these things exist together, intellectual and developmental disabilities, which is not always the case. There are a lot of autistic people who have an intellectual disability, a lot of people with cerebral palsy who have an intellectual disability, and then there are a lot of people for whom those things are completely separate. So in contrast to developmental disability has to emerge in the first 22 years and can include intellectual disability, but can also include physical disabilities as well. So here are examples of common developmental disabilities, and there's variability, I think, in how well these are understood and how well these are recognized. Fetal alcohol spectrum disorder, for example, is an area that is not particularly well funded in terms of research dollars. There are not a lot of experts nationally in working with kids with FASD. And so kind of understanding that all developmental disabilities are not the same, not only in terms of development, etiology, and presentation, but also in terms of what families can access that is associated with those diagnostic categories is really important just for a systemic perspective on how people with disabilities might experience the world and experience support. I do want to focus on some of the main features of autism and related disabilities, because I think that in my experience, these are commonly the behaviors and symptoms that people have the most concern over or questions about how to adapt, especially in terms of services, both educationally and in the mental health sphere. People with autism and also related disabilities do have kind of hallmark difficulties and differences with social communication skills, and then the presence of a very specific set of restricted or repetitive behaviors or interests. Autism, again, as you must know, is defined by a behavioral phenotype. Although there are genetic conditions that are highly associated with autism, there's no genetic test for autism. And so we look for the presence of 3 social communication symptoms, as well as 2 out of 4 restricted or repetitive behaviors or interests. Social communication in this context just refers to how do we interact with others and get along with others in the world. And this is not an exhaustive list, but just an overview of some of the major kind of social communication differences that you might see in this group. And I'm especially trying to highlight things that might create tension or the need for adaptation in a clinical setting. So we look at the range of both understanding, receptive language, and use, expressive language of spoken language. We look at differences in nonverbal communication, and then difficulties with things like friendships, peer relationships, and abstract concepts. So in terms of language, some of the kind of hallmark characteristics that we might see and could include things like that are more kind of straightforward, like difficulties understanding or retaining multi-step instructions, difficulties answering questions in a straightforward way, or understanding language at all. The need for alternative communication options, such as through picture-based systems or speech-generating devices. And then often there can be mismatch between what is said and what's understood. So for example, a child might have a lot of expressive language and be able to say a lot of things and produce a lot of speech, but that doesn't necessarily mean that they're understanding everything that is said to them. We see differences in nonverbal communication, so not maybe a lack of a preference for making eye contact, or for differences in how eye contact is made, fleeting, overly intense, absent. It can look like all different things. And inappropriate or mismatched facial expressions. So this is very commonly seen in kids where their facial expression doesn't match the tenor of the situation. So someone laughing in a situation that might be overly serious, or where other people are upset, or being very flat affect-wise all of the time, regardless of what's going on around them. Autistic kids might have difficulties understanding or producing gestures or understanding what they mean when other people use them. And then oftentimes there can be misinterpretation of the tone of others. So maybe not picking up on the subtle tonal qualities of other people's language, or they themselves might have like very monotone language, or their tone might be a little bit odd in ways that make it difficult for other people to understand or interpret how they're feeling. And then certainly in a clinical space, we experience a lot of adaptations that are required around a tendency for kids to be very overly literal or concrete in their thinking. So abstract concepts can be very difficult. Not understanding euphemisms is one of these classic characteristics. So when you say it's raining cats and dogs, and they might be looking out the window to look for cats and dogs. Restricted and repetitive behaviors, kids have all kinds of strange and interesting behaviors that they do, which is part of normal, typical child development. There are a subset of very 4 specific restricted and repetitive behaviors and interests associated with autism and related developmental disabilities. And Mary, I'm going to do this slide, and then I'm going to get to your comment because I appreciate it. So the first is repetitive behavior. So this could be vocal repetition or physical repetition, repeating words, phrases, sounds over and over again, or engaging in hand or other body movements. Repetitive behavior vocally can also manifest in kids repeating things that they've heard either previously, or repeating the last thing that you just said. So if I said to a kid, like, let's go to your next center, then they might say, go to your next center. And this can create communication difficulties because people might think, oh, they've processed, they understand what they're saying, but it's actually just like a word for word repetition without necessarily the understanding that comes behind it. Autistic children can have very intense interests. This is also present in a lot of people with broader developmental disabilities, and these could be intense either in their focus, so interests that seem unusual for a person's age. So I used to work with a kid in Philadelphia who was very, very interested in their SEPTA, their public transportation system, and he used to sleep with the SEPTA bus schedule under his pillow every night and then would review it in the morning. And for an 8-year-old kid, that was a little bit unusual in terms of its focus for a kid that age. For others, that might be unusual intensity. So an interest that seems very natural, like Minecraft or dinosaurs or the planets, but it seems to be all-encompassing and all that they can talk about. They might have a hard time talking about other things. You could see how this could interrupt a therapeutic space too, especially if there is a desire to, no matter what you're talking about or trying to convey, the child's always trying to bring it back to their own interests. And this also might manifest in distress if they're interrupted. Certainly, we think a lot about sensory considerations, which could either be sensory avoidance, overly sensitive to sights, smells, sounds, touch, to a place that evokes a lot of distress, or kids can be seeking out sensory input. They want to touch things, they want to smell things, they want to spin things like Sandra's grandson, or spin himself to get that sensory input. And then kids can have both. You can be avoided and seeking at the same time. And then rigidity and resistance to change, being very routine bound, having an idea in your head of how to do something. And then even if you haven't communicated that, if someone interrupts that in some way or does it in a way that you didn't expect, that all of a sudden becomes very distressing. And you can see how some of these behaviors, especially rigidity, could be viewed as the child being oppositional, being difficult, not wanting to follow directions, when rather it's very much related to internal pressure to be rigid around certain routines. I want to share Mary's comment that she says, my adult son has intellectual and developmental disability and struggles with social communication. Social situations are so stressful because he can't interpret tone, facial expression, abstract ideas, but he wants so badly to have friends. This has been the biggest struggle of his life. Mary, I'm sorry to hear that that's been such a struggle for him, and I hope that he and you both know that he's not alone in that. You can see how if you are trying to make relationships with people who don't understand all these characteristics about you, and they don't understand where you're coming from, and they don't understand what makes you you, because they don't experience the world in the same way, it can be very difficult to establish relationships, especially in childhood, when kids are much more likely to seek out similarity than they are difference. And so certainly difficulties making or maintaining friendships is a hallmark characteristic of autism and related disabilities, and it can be very hard. And I'm sure that a lot of your services probably focus, if you're working with kids in general, but also disabled children, might also focus on their ability to make and keep friends. I wanted to highlight just a few features and what this might look like in a kind of provider setting. And these characteristics show up and can cause misunderstanding anywhere. So I've done this talk for mental health providers. I've done it for crisis providers where they're kind of supporting people through a behavioral or mental health crisis. And then we've done this for first responders. And in the end, a lot of the features kind of show up in the same way and can cause the same types of misunderstandings with someone who's there who's trying to help you. So for you, that's you as a mental health provider. So if someone has a mismatch between what's said and what's understood, to the outside, it might be like, well, they're talking a lot. So why are they acting like they don't understand me? Clearly, they're being rude. They're being oppositional. They're not being compliant. Or in a mental health space, we might think that they're being like non-engaged, right? Without the understanding that it might be that they're just not understanding our spoken language. Trouble with multi-step instructions or rigidity even can result in a perception. I'm telling them how to change their situation. I'm telling them like what they need to do to make things better, and they don't care. But really, it might be that they're not sure how to execute that plan because it's a little bit too complex. Inappropriate or mismatched facial expressions can cause misunderstanding because it could seem like, well, they're not engaged. They're not motivated to participate. They're not even looking at me. So clearly they're not hearing everything that I say. When in reality, a lot of people with disabilities will tell you that their ability to pay attention to someone is actually a lot better when they're not forced to make eye contact. And that also relates to the last point, like lack of eye contact doesn't necessarily mean that people aren't paying attention to you. And then repetitive behaviors, repetitive words or phrases or sounds might be like, well, why do they keep saying that over and over again? They must be trying to annoy me. The number of times I have heard autistic kids described as oppositional is quite flabbergasting. And the vast majority of kids with autism don't also have co-occurring oppositional defiant disorder, but they're often seen that way, specifically around these types of behaviors. Rigidity and interruption of rituals can cause a lot of strong reactions. And so for you who's trying to like share a strategy, you might be really excited, like, oh, I have this great idea of how you can make a friend. How about instead of going to this room at school tomorrow, you go to this one instead? And then the client gets very upset. And the idea is, all I did was suggest a new strategy. Like, why is this making them so upset? They must not be motivated, or they don't like what I have to offer. When it's actually not about your suggestion, it's more about their anticipation of a disrupted routine. And then same thing, we don't always think about sensory context of our therapeutic environment, where some of us have fluorescent lights, or some of us have ambient noise, or some of us are using a noise machine, and that noise machine happens to be at a frequency that's really distressing to our client. And so it's like, I'm just trying to help and they're getting so upset. And we might not necessarily realize that it's the sensory input that's making them upset. So for all these reasons, you can see that there are a lot of difficulties with a mismatch between characteristics of kids with disabilities and the social norms and expectations for how they go through life in general, but also how they might engage in therapeutic service. And so for those reasons, you can see why mental health in the disability community is a serious health equity concern. And we're going to talk about prevalence rates of people with disabilities and co-occurring common mental health conditions. But the important thing to know here too is that it is often very common that even identified concerns are resulting in unmet needs. And on your side, again, like this is also bi-directional. Providers will share a lot that they wish that they had more access to information and more support and more peer supervision and more training around how to best support the disability community. And that's a systemic issue also, that you don't get always the support that you need to be able to foster these types of effective relationships. Okay, I'm trying to monitor the chat while I go. So Kelly has a question about PDA, pervasive demand avoidance and autism. Kelly, I have a section where I'm going to get to some diagnostic categories of mental health concerns. If it's okay, I might table your question until then, because I think it's more related to that content. And then I just want to highlight that Jennifer is sharing lived experience, that her daughter, autism without an intellectual disability, and I talk a lot about how all behavior is communication. What is the behavior, however frustrating or unpleasant, trying to communicate? Absolutely, absolutely. And that is one of those society meeting the needs of kids, right? If it's not apparent what the behavior is trying to communicate, how do we find a communication strategy that's going to allow them to express themselves in a way that can be understood by others? I love this quote from Maslow. I suppose it is tempting if the only tool you have is a hammer to treat everything as if it were a nail. I'm sure a lot of people have heard this before. And this I use to highlight this idea also of diagnostic overshadowing, which happens a lot with co-occurring mental health in the disability community. There is a huge tendency for when kids with disabilities go to a primary care appointment, or they talk to a school counselor, or, I'm not trying to vilify these professions, but just they go to a provider and share mental health concerns. A lot of times it can be very much reduced to, well, that's just his autism. That's just his intellectual disability. And then that becomes the overshadowing diagnosis that doesn't make space for the fact that there could be also a clinically significant co-occurring mental health concern, right? And we know that diagnostic overshadowing happens quite a lot in the mental health space and the disability intersection. And so it's really important that we are intentional about screening and assessing and taking people seriously when they do express concern. So this is just another way to highlight that health disparity for disabled people who also have co-occurring mental health concerns. It would be impossible to go through the entire DSM and talk about intersectionality of the DSM and IDD. So I'm going to focus on more of our common mental health concerns, as well as like areas where there has been a lot more work. Before I get into talking about anxiety, depression, and then self-harm and risk assessment. Kelly, I'm going to go back to your comment about PDA. So pervasive demand avoidance in autism has really increased a lot as a concept, I would say, over the past 5 to 7 years. And the idea that, like, similar to kind of an oppositionality, like people with autism are kind of primed to have pathological negative reactions to any kind of demand or request or societal expectation that is put on them. And it can be a lens to view all of their behavior as pushing back against these types of requests and demands. It's a very controversial topic. I don't want to get too much into it, but I will say, as a psychologist in a room with a lot of other psychologists and licensed mental health providers, that PDA is not part of the DSM, and it is not necessarily associated with any differential assessment, differential intervention options that can't be addressed through a different lens that already exists. So, for example, considering that resistance to requests and demands might be motivated by something else, like anxiety, like mood disturbance, like a medical issue, like pain, right? And I worry that over-reliance on PDA as a concept is at the expense of a more comprehensive psychological and medical assessment to identify something that could be very seriously concerning and driving behavior. So that's where I'll leave it now. If you have other thoughts about that, or others want to maybe chat about that at the end of the presentation, if we have time, we can definitely do that. All right, so we're going to talk a little bit about anxiety disorders. And obviously, y'all work with children and youth. You know some of these hallmark considerations already when you're working with kids, that you have to be a little bit more intentional about how you screen for cognitive symptoms and thoughts and worries. Kids might have limited insight, especially insight into when worries become excessive and not reasonable anymore. We know that very young kids might not meet the full criteria for anxiety disorders, which doesn't necessarily mean that there isn't anxiety worthy of intervention. And then there are often behavioral indicators more in kids than adults: refusal to follow directions, tantrums, withdrawal. And a lot of kids who are anxious may appear inattentive, especially if they're kind of internalizer anxiety kids as opposed to externalizing anxiety kids. I bring these up knowing that you know this already, but also because these are also true in kids with disabilities, but they might be kind of exacerbated even. So I think that they're worth talking about because it might be even more important to make these as considerations. Then there are additional considerations that might not be as apparent in the community of people without disabilities that is very relevant in this group. So I said I'd talk about prevalence. There's high comorbidity of anxiety and autism/intellectual developmental disabilities, approximately 40%, although estimates range quite a lot. Some of them are up to 80% or as low as 20%. And I want to highlight the work of Connor Kearns. Connor Kearns was someone who was actually at Children's Hospital of Philadelphia as a fellow when I was there in my fellowship phase as well. She's done some really seminal and fascinating work around the atypical presentation of anxiety disorders, particularly in autistic kids, but more broadly in kids with intellectual and developmental disabilities as well. So as we go through certain anxiety disorders, I'm going to talk about those specific presentations and how it might influence your assessment of anxiety in these kids. But I love her quote: "Exacerbated and clinically impairing anxiety around the hallmark features of ASD." That's what we can expect often in autistic children. And she wrote this back in 2014, before there was a preference to move away from ASD to more just autism. And that's why the quote is that way. Certainly in kids with autism, anxiety is very highly reported by families as challenging behavior. So we have a lot of parents who say, my kid's got behavioral concerns, oppositionality, maybe the school makes a referral. And when you do a deeper assessment, people have absolutely no idea that anxiety was driving behavior. So let's look a little bit at how the presentation and prevalence of anxiety might differ in kids with disabilities. So in general intellectual and developmental disabilities, anxiety runs around 20% in unspecified IDD, which would include kids with global developmental delay who might not have a formal diagnosis yet. Very high in Rett disorder, around 73%. Fragile X is one of those genetic conditions which is highly associated with autism, although not uniquely and not exclusively. Around half of kids with Fragile X are reported to have anxiety. TS around 14%, and then 9% in Down syndrome. It's a little less common in kids with Down syndrome. Separation anxiety is one of the anxiety disorders that actually looks quite similar in kids with disabilities versus kids without disabilities. And so in kids with disabilities, you'll see the same kind of distress and anticipation of separation events. They're a little bit less likely to report worry about loss or a scary event, although not exclusively. The focus of what that scary event is can be a little bit different. So for example, a lot of kids with typical development will talk about, like, I'm worried that my parent's going to get in a car accident, or like their plane is going to get into an accident, or they're going to leave and not come back, or there's going to be a natural disaster, right? Those are like very common. Those will happen in kids with IDD, but a lot of kids with IDD, especially autistic kids, might have very specific and unusual fears. I used to work with an 11-year-old who was terrified of his parents getting haircuts because he thought that the barber was gonna slip and sever the head from the parent. And so that was his specific fear that fueled separation anxiety anytime the parent went anywhere, regardless of whether they had any intention of getting a haircut or not. He was convinced that every time the parent left, they would be going to get a haircut and this horrible thing would happen to them. So you can see how like the focus is a little atypical. It's about 14% separation anxiety in kids with intellectual and developmental disabilities. And they also will kind of report those somatic complaints like, don't leave, I'm sick, I have a stomach ache, I have a headache. Again, you might see an increase in tantrums upon separation, complaints of being sick, being a caregiver shadow around the house, insistence on caregiver present at bedtime. This is very much exacerbated in kids with IDD because many kids with disabilities have intense sleep difficulties. And so they're already prone to not being able to fall asleep well. And so if a caregiver presence is reassuring, then you kind of have a bit of a double whammy there. Okay. Separation anxiety in other IDD is not very well documented. It is present and tends to be more present in 2211.2 deletion syndrome, but not as common as other anxiety disorders. All right, social phobia is very interesting and different, especially in autistic kids versus youth in general. So normally when we look at social phobia, social anxiety, we think about fear or distress in social situations. There's that component of like worry about negative evaluation. What are people going to think of me? They're going to think I'm stupid. They're going to think I'm dumb. And then avoidance of situations or endurance with great distress in social situations, including performance-only social anxiety. About a third of kids with IDD report some symptoms of social anxiety. And again, some of these also can be very similar, either that shyness or the externalizing tantrums anytime they're perceived to be criticized or in a situation that makes them uncomfortable. In autism, though, social anxiety, the focus tends to be quite different. So kids will report not anxiety, not worry, not fear of negative evaluation, but just like, I am not comfortable. I hit a wall. I don't know what to do. Like, I feel like people are going to ask me a question and I'm going to have no idea how to respond to it. So you can see how this relates to peer difficulties as well as some social communication underlying difficulties. And they will engage in a lot of social avoidance because it's distressing and uncomfortable. And it often will present without fear of social rejection, in contrast to how it will present in typically developing kids. So that is a different focus. And so if you're doing assessment for social anxiety in an autistic child, you might want to make sure that you're asking about these nuanced worries or experiences as opposed to maybe what's typically included in like a scared or an ATIS or something like that. Oh yes, Yolanda, some children, teens will run away when anxious in social situations. Could be like a trigger for elopement. Michaela, yes, we will make sure you have the slide deck. Yeah. And social anxiety is reported in 7q11 and then Fragile X as well, more than in other diagnoses. Okay, generalized anxiety. Always such a hard one, right? We have excessive worry, apprehension, this overall sense of doom, the sense that it's very much related to mood and general kind of dysphoria more than other anxiety disorders. And that idea that like the worry is difficult to control. We also will see the physiological symptoms, the pervasive headaches, the lack of appetite, difficulty sleeping, oversleeping associated with GAD. And again, around a quarter to a third of kids with IDD will report some GAD. It is overlapping in some ways, for sure. GAD tends to be harder to evaluate in terms of like kids who don't have a lot of spoken language, because the worries behind GAD and that sense of apprehension often rely so much on our ability to kind of express how we're feeling and talk about those thoughts and determine verbally whether they're excessive or not. So it's tends to be a little bit more well documented in kids with fluent language than kids without fluent language. You do hear what if concerns, what if this happens, what if this happens, safety concerns, the idea of checking up on loved ones, like the kiddo checking up on his parents. And then in kids with IDD, you might see more like overlap with their rigidity or their fear of novelty. So I'm reluctant to try new things. I don't want to do things out of my comfort zone. I'm going to have greater tantrums during transitions or times of change. There are also some specific GAD focus in autism. So kids with autism report quite often that their pervasive worry is worry about other people following or breaking the rules. And this actually causes a lot of like great distress and inability to enjoy situations because they're so concerned, especially in a school setting, you can see this come up, about whether someone else is going to follow the rules or not. There's a lot of reports around kids worried about having their very favorite items or activities taken away. You can imagine that if you're a kid who has an intense interest in something and it's been leveraged against you as a punishment in the past, or even you got to go to school so you can't sit at home and play Minecraft anymore, that emotionally is actually going to be a lot more impactful in some autistic children than it will in kids in the general population. And they might really worry about it. And they do report this as an excessive worry that consumes quite a lot of their life. Again, fear of novel situations and fear of change overlaps with that rigidity. So certainly those first two are not part of typical assessment for GAD, but they can be so all-consuming. So I think it's really important to consider them as part of maybe the broader disability-specific presentation of generalized anxiety. Generalized anxiety and other IDD is less common, or it's just less well captured or reported. And again, like this is very language based, I think, more than a lot of other anxiety disorders tend to be situational enough that you can identify them based on observation, which is not the case here always. And then that overlap with mood can also be difficult. Yolanda, it reported with some of my clients with IDD increased after COVID-19 pandemic and loss of loved ones. Worrying and fears increased in the what if surge. Yeah, what if someone gets COVID? What if they get the bad one this time? What if someone else I love gets sick? What if this person who just has a cold is going to die? For sure. I think COVID-19 caused a lot of trauma for a lot of people, and that this is pervasive enough and it encompasses that health concern that I would understand why you would see an increase in distress following the pandemic. Okay, Erica asked a question that is, I think, important enough that I'm going to take a digression to answer it really quickly. She says, random question. I had learned many years ago to refer to this population as the child or person with autism rather than autistic child. Is this no longer best practice so I can be respectful? Thank you, Erica, for your dedication to respectful language. What we have learned is that there are varied preferences in the community for person first language, which identifies the person first, a child with autism, versus identity first language, which would be identity first, an autistic child. Especially in the autism community, many outspoken and highly fluent people with autism will say that they prefer autistic because they don't see their identity as being separate from their autism, and they find a point of pride in their autistic identity and connection. Other disability advocates prefer person-first language. And so what I try to do is I try to use both and switch back and forth. I'm sure I'm not 50-50, but I do try my best to be balanced. And I do heavily lean a little bit more on identity first when I'm talking about the autistic population, because that has been so strongly expressed as a preference. When we talk with people about person first versus identity first language, our recommendation is treat it like you would a pronoun. So you mirror what people use. So if I hear a parent say my child with autism, then that's what I will use. Or if a person refers to themselves as I'm an autistic advocate, then I'll use identity first language. And then it's okay to ask, and then also to consider that we don't always have to identify a person as a person with a disability at all. So I hope that that helps. And Irene, as an autistic adult, she says that most other autistic adults prefer autistic because they feel like autism is inseparable from their identity. And I agree, it has been more of a recent language trend. Irene, thank you for speaking from your personal experience and sharing that. I can't say it any better than an autistic person. So I'm going to move on, but I really appreciate the question and opportunity to discuss language. All right, specific phobia is a very interesting one because by nature, the content of specific phobia can be so diverse and interesting. So normally we'll see immediate and persistent fear, avoidance of an object or a situation. Kids might be afraid of animals, bugs, natural environment fears, heights, for example, blood or needles, or situational, situational as heights or being in a closed space. So about 40% of kids with autism or IDD will report specific phobias, and they are the most commonly endorsed anxiety disorder in autism. Again, this might be a little bit overinflated because they are so highly situational that they're easy to identify upon observation, but it is also very common. And we do see the range of specific phobia that we see in typical development in the autistic community and the disability community, but especially with autistic kids, we tend to see very specific atypical fears. And in Connor's work, these are the most common specific fears that she identified. Fear or just incredible distress around sounds that are like of a certain pitch, so a baby crying. And I was part of her study, and we talked to a lot of parents and a lot of kids who said that they would avoid places like the grocery store because they didn't want to have to hear like a toddler or a baby crying because it was so distressing to them. Specific stores, like we don't go to Walmart because that's just too overwhelming and too distressing for the child. Haircuts, like I talked about. And then one of the interesting ones was songs, where we talked to some families whose children would have just absolute distress moments in a grocery store because a specific song was played on the radio. And I'll never forget one example of it. There was a kid I used to talk to, and I did his anxiety assessment. He hated the song Hey Soul Sister by Train. And if you were around, I don't know, when was that? 15, 20 years ago when that song came out, it was everywhere. And there was a period where this child could not leave his house because he could not avoid public spaces that would play Hey Soul Sister. Yeah, thank you, Christopher. I mean, it is a valid point, but the extremity of this reaction just was just so interfering for his life. So I would just think a little bit about additional phobias that may not be as common. And even when you're talking with parents, I think it's okay to give these as examples and be like, hey, does your child have anything that just seems a little like maybe not everyone has distress around it, but maybe your kid does, and you might get some interesting information. Specific phobia and other IDD is reported a little bit more than some of the other anxiety disorders. It has increased incidence in Fragile X, 22q, and then Williams syndrome. And there's been some research to specifically say that children with Williams syndrome have specific, very higher incidence of specific phobia around noise, blood, and injury type for whatever reason. Skylar's son is 10 and he's autistic and he can't listen to Adele. I wonder if it's that tenor of her voice too. Yeah, we'll never know, I guess, but thank you for kind of highlighting that point. Okay, we'll talk a bit about mood disorders as well. So I'm going to focus mostly on depression, just for brevity and our ability to get through everything. So we think about, I mean, you all know the symptoms of depression, and certainly Specifically, I'd highlight in the disability community, the irritability factor as a proxy for depressed mood is definitely present and important. Sleep issues can be tough because a lot of kids don't sleep anyway, but if you see increases in sleep changes, that can often be a mood disturbance. It's less common, especially in kids who are not as verbal, to have insight into things like a sense of worthlessness or inappropriate guilt. So you might need to focus a little bit more on behavioral indicators. So I will talk more about some of those, but I do want to highlight that the cycle of depression in kids with disabilities is the same as it is with anyone else, right? Like these are all interrelated, and it doesn't matter where it starts. But if I have a sad mood, then I don't have a lot of energy and I avoid things, and then I'm isolated and I don't get to do fun things. And then that just perpetuates my sad mood. So this cycle is going to be exactly the same in kids with disabilities. And I do think it's important to highlight the similarities as well. Estimates for mood disturbance in kids with disabilities ranges from 30 to 40%. We do know a lot more about depression in autistic people. They are 4 times more likely to suffer from depression in their lifetime. And in autistic people and in the disability community, you might see more of these types of indicators of mood changes. So avoidance or withdrawal, more than usual. Again, it's easy to say like, well, he doesn't want to go out anyway because he's not that social because of his disability. But if it's a marked change, that's important. And we don't want to engage in diagnostic overshadowing and not looking into that more. You might see increases in not following directions or refusal. So that irritability might present in oppositional kind of behaviors. Inactivity, narrowing of interests, especially loss of special interest, is very concerning, especially in autistic kids. So that's something to pay attention to. And then irritability, agitation, and changes in sleep and eating, just like you would consider in any other kid. And families will often complain about challenging behavior also in depression, especially when those symptoms are externalized as opposed to internalized, which again, to the point that a participant made earlier, sometimes behavior is the only way kids have to communicate. And so if the only way they can tell you they're upset is through behavior, you're going to see more challenging behavior. Not everyone's going to associate challenging behavior with depression. It's not always like the most classic presentation. So it's just important to know that this might be worthy of special consideration in this population. Depression in people with IDD. So there's been some work to look at the difference in people with high support needs versus low support needs, because we know that assessment and intervention is not going to be the same in those two groups. We have to be respectful and considerate and meet people where they're at. And people with high support needs often are left out of adaptations of common mental health considerations because either there's the assumption that they can't participate or their symptoms aren't even assessed in the first place. So in people with disabilities and low support needs, their symptoms tend to align more with classic DSM-5 symptoms. If the person has high support needs, you're much more likely to see the behavioral presentations in terms of irritability, fatigue, movement agitation, which has to, again, be above and beyond what might be their typical repetitive movements. So that's very important to consider, like the threshold, other externalizing behaviors, and reduced appetite. Okay. So that's like a quick and dirty of some of that intersectionality in terms of symptom-specific presentation in IDD. And then we can talk a little bit about what that means for mental health and risk assessment. So obviously, if you're working with youth, right, you're doing a lot of behaviorally based assessment anyway. Typically, a standardized assessment is done with a kid of a certain age, and then in younger kids, we might focus a little bit more on caregivers and parent report and observations. And certainly, we always want to make sure it's about interference so that we're not over pathologizing things that are just part of the natural human experience, right? There might be more intense need for observational assessment in people with disabilities. So looking for patterns in behavior, but considering even things as specific as the time of day, the situation in which it's happening, the environmental cues, who's present. And To obtain these patterns, it might be more important with people with disabilities than in the general population to gather information from multiple sources. So data collection from parents at home, but also from school could be helpful in identifying some of these patterns. And as always, kids with anxiety may look much better at school than at home, where they have a little bit more trust to be their authentic, irritable selves. Like in youth, older people with disabilities might also not divulge their feelings or their thoughts if you don't ask. And it's going to be really important to assess for their understanding of emotional language. Emotional language by nature is abstract, and we know that people with disabilities have difficulties sometimes with abstract concepts. So we might need to get really specific information from them. What does anxious mean? What does nervous mean? How do you know when you're sad? How do you know when you're scared? Or if they don't have the language to complete those, you might need to rely more on visual supports, which I will talk about in a minute. So again, like you would with a younger child, you want to ask specific questions in the language that the child understands. And you can start with open-ended and then move to ranges of options. I do think like scaffolding language with people with disabilities can be really important if they do not have fluent spoken language. So it's okay to start with well, what do you think is going to happen if you get the wrong answer? But then you might need to provide a more limited range of options. Like, well, is it that you think you're going to get in trouble? Do you think your grade is going to be bad? Do you think that everyone is going to know and you're going to look stupid? Like, you need to maybe scaffold that a little bit more. And Carrie says a good reminder is to ask the person and not just make assumptions based on our lens or experience. And I appreciate that comment so much because, you know, we all have our shortcuts, our heuristics, right? And as people who've worked with a lot of kids, we might make assumptions about why people do things based on our good experience and our good clinical judgment. And it just might be that one time when it's actually driven by something else and we didn't ask that makes the difference. And we can never, though not all of us, some of you have expressed that you are members of the disability community, not all of us are. And so for me as a non-autistic person, I do not know what it's like to walk through the world as an autistic person. And so I can't make assumptions about how they're going to experience or perceive information, situations, or input. Here are examples of some visuals. So to make sure that we don't exclude people who have limited spoken language, a lot of people with fluent language benefit from these as supports as well. All of us are not as good at talking about our feelings when we're in moments of distress. And so I tend to offer visuals just regardless. So things that include how pointing on a body, how does my body react to being nervous? Where do you feel it? What does it feel like? Emotion faces, we use a lot of scales, especially to identify intensity of feelings or intensity of how hard a situation is. So like hey kiddo, where's haircut? Your dad's getting a haircut. Where are you on that thermometer, right? That's going to be all the way up there at 100, where a friend breaking a rule at school might be down in the orange zone. So all kinds of visual supports. And if anyone is interested in access to visual supports, I'd be happy to help you with that. I do want to share with you some pictures that I am sharing with permission from a former client of mine who really struggled talking about his anxiety, but was very vested in being an artist. And so we gave him the opportunity to explain himself pictorially. So he liked my color scale. So he used the color scale and he used pages to kind of highlight, here are the different situations in which he's likely to feel anxious. And so open-ended expectations from his teacher were hard. So when the teacher said, find the answer yourself, he was at a 1 to 2 out of 5. I don't know what the answer is. Where do I find it? And here's his classmate handling the situation totally fine. And here he is stressing out and sweating, right? Here is another situation. This is his mom getting her hair washed before a haircut. And in terms of his happiness scale, where the black it's the opposite of what you think. So this is how calm is he? He is 0 out of 5 calm. It's black like death. He says, why does my mom bring me to this kind of stuff? Why do I have to be here? And he's crying on the couch. And then he said, if you think the outside of me is bad, you should see the inside of my head. And this is what he drew. It's him in some kind of vehicle, and there's a red alert, and someone's screaming, quarantine, quarantine, and we have to control him. How does it stop? I don't know what to do. And this is what he experiences whenever he's in a situation that evokes anxiety. And how helpful, right, as a provider would it be to have this level of insight into our clients? And his family was just so shocked that this was the extent of his distress. But it really helped us develop a more comprehensive treatment plan for him. So he's a kid who a traditional risk assessment or risk assessment in general might be a little more challenging in the intellectual and developmental disability community because of the nature of how we structure our assessments. But it's important to know that suicide risk is heightened in the disability community, 9 times higher in autistic people than in the general population. It is higher in autistic girls because they often go unrecognized for a long time. And it's higher in people with low support needs versus high support needs. Risk factors for suicide risk or self-harm risk include low social support, experiences of bullying, and masking, which has been talked about a lot in the autistic community, but also in the disability community. The idea that you have to pretend like you don't have your autism symptoms to appear as quote unquote normal as possible to be able to get by in the world. And you can imagine how emotionally taxing that is. And so it is associated with increased risk. Our traditional risk assessments are focused on written and spoken communication for the most part. They are highly dependent upon insight, and a lot of them are not validated in the disability community. So we know the elements of good risk assessment include, like, what's the history of risk, severity? Do they have intent to self-harm or hurt or kill themselves? Do they have a plan? Do they have access? And then importantly, what are the protective factors? Risk assessment should still include all these things. Okay, so like this is all still very salient and very important. Here are some assessment options that seem to be a better fit in the disability community than maybe some of the ones that are more commonly used. So the Ask Suicide Screening Questions, or ASQ. There is a suicide behavior questionnaire specific to autism spectrum conditions. These are publicly available. And then this, I don't know if folks have used, you probably have, the Stanley Brown Safety Planning Intervention. But if you do have concern for risk, the Stanley Brown is very brief. It is extremely concrete, which is helpful for people who like concrete information. It's done step at a time, and then it includes a teach back component. And there's options for virtual training on the Stanley Brown if you feel like you need to do a lot of safety planning for kids with disabilities. I highly recommend it. And it has been kind of documented in some emerging literature as helpful. Erica asks, how often is suicidal ideation utilized as a mean to express anxiety, depression, negative internal experience versus a true desire to die in the autistic community? Excellent question. So I'm going to say 2 things. First, I'm going to say it happens a lot. When you have a community that doesn't necessarily always have the language to well articulate how upset they are, sometimes it's an easy shortcut to say, I want to hurt myself, I want to die, I wish I wasn't here. And it's not a true desire to die, like you say. It's more, I want you to know how incredibly upset and distressed I am. That being said, a lot of people, especially autistic people, will report that they're not always believed when they talk about suicidal ideation. So I do think it's very important to consider in the back of your head that, like, this might be an expression of distress, which is important to know, but to also do a full risk assessment to make sure 100% that there aren't true underlying ideations that are going to go missed. And you well set me up for this line, right? That considerations for increased ideation includes that many people with IDD report not being able to express suicidal thoughts, right? So they might do it in other ways. You could see changes in repetitive behavior. You have to separate out increases in self-harm around self-harm that might be naturally occurring in folks with the disabilities, which does happen. Melanie asked about special interests that focus on suicide and death. Absolutely. A lot of people with disabilities have special interests in death, and it doesn't necessarily mean that there are intentions around hurting themselves or killing themselves. What I would be looking for are increased ruminations around death, and increase in those suggestions, or perseverations around a plan or access that didn't exist before. So that's really important. And I think it's also important in this in this community to know that statements about death may not be accompanied by distress in the way that it might be in other kids. So good practice adaptations for risk assessment include clear questions, again, offering options. You might need to adapt some more standardized risk assessment tools or use the ones that I suggested. Adding visuals or scales like the ones I shared when possible to help aid in your completion of a risk assessment. And then clarifying or mirroring language when possible. So if someone is calling, we did a whole training series for crisis counselors, 988 crisis counselors, and a caller called up and was talking about dark thoughts, and the person was like, well, that means that they want to die. And it's like, maybe, but you can't make assumptions like we said before, right? So ask clarifying questions. What do dark thoughts mean? If you suspect that equates with suicidal ideation, ask about that. But then it might be helpful for this person, if that's how they're framing it, to then you use the word dark thoughts when what you mean is suicidal ideation in the rest of the conversation. And then again, like the participant brought up, we want to parse true ideation from intense interests or obsessions that could be associated with IDD or also OCD, right, which can also co-occur. And then most importantly, a lot of people with disabilities need time to answer, right? They're not going to answer right away. They might need additional processing time. And so making sure that you're not rushing through a risk assessment will be really important. In some work that's been done in partnership with people with autism and disabilities around risk assessment, their #1 recommendation, this is taken verbatim: believe when someone says they feel suicidal, even if information comes to you in an unexpected manner. And then finally, just a few slides on some mental health interventions and supports. Again, you know, a lot of the considerations that we would have for therapeutic services are things you're probably already considering in your work, given that you work with youth, right? So we consider the development and the age of the person. And you might need to think a little bit more through developmental stage with a disabled client than you would necessarily one who is typically developing. Absolutely thinking through how the client uses language. Do they have fluent speech? Do they have some words? Do they use an alternative communication device? It is sometimes true that like parents may not necessarily bring supplemental communication devices that the child might have access to at school. So it could be worth asking about that because it could really aid in your relationship building. Considering whether there is level of insight, again, this is true for all children and youth. And then in the disability community, you might need to rely a little bit more on a care team than you would with others. Like there might be an associated speech pathologist who's working with the kid, or a school social worker, or somebody else, like they might be in a social skills group at school. So thinking through who else might be providing similar types of supports for them. Anxiety, right? We know that symptoms are created around or centered around a perceived loss of control. So how do we create control in this population? For kids with autism and disabilities, increasing predictability is always a good thing. Making our expectations clear. So ways that we do this are with visuals, through using schedules like the one I have over here, communicating things in multiple ways. So supplementing what you say with things that they can see, and then giving advance warning and support for transitions. So we talked a little bit about, and we heard in the chat about how social situations can be very difficult. And so sometimes putting out the rules or steps of how do you ask someone else to play, or like, what are the rules for playing a game, and having them posted and shared with everybody in a non-stigmatizing way can help increase engagement and reduce anxiety around a specific situation, right? So here are the steps to inviting someone else to play a game. Here are our rules for games and how we're supposed to show up for each other. Things that most of us understand and know, and even kids like pick up on. It's a lot of people call it the hidden curriculum, like the things that we just don't have to explicitly teach, but considering what can you make explicit that isn't explicit yet. Supporting skills development that aligns with identified fears can be really important. So I talked about social rules and expectations. Creation of coping strategies is going to be really similar than you might with some other kids. We want to provide environmental support. I used a couple examples of some coping cards that I worked with. That child who created the quarantine, the quarantine drawing, he liked coping thoughts. That was something that he thought was really helpful. And so that first coping card included thoughts related to fear of his dad being gone, both in terms of like he's going to get a haircut and then other types of fears. And then we incorporated also pictures of some of his special interests. So these like little tiny monster truck car things were a huge special interest of him. He's going to use a card more if he's motivated to look at it, right? So we try to incorporate those types of interests with coping strategies. There's other ways to support the environment. And I gave an example of a social support. Kids sit down to lunch. It's very unstructured. It can create a lot of social anxiety, especially for someone who doesn't know what to do in that situation. And so we have a support called a conversation menu, where you have like a card that can be laid out for groups that has an identified topic of conversations, like what's the best pet? What's the best sport? And a kid who needs some social support can get this in advance, prep their answers, and so they're ready and prepared to have a conversation. And again, you know, we have our cycle of depression, and a lot of these skills can then, you know, support behavioral activation. So they give us the skills to do more meaningful things, to be more included, to feel like you're getting more out of those interactions. And that might give us more energy and help us to feel better overall. So again, it's so important just to highlight that the processes are the same, right? This isn't different just because a child has a disability, but we just need to think about how do we adapt the skills component of it to be a good fit for them. In terms of behavioral activation, scheduling activities that are not focused on what we think the kid wants, but what they actually want and what they're interested in, even if it's something that no one else is interested in, can be really important. But also thinking through how do we support meaningful inclusion for them, social inclusion through some of the strategies I shared before, coordination potentially with in educational environments or after school environments so that they're getting support. It can't all be just like, you're coming to outpatient therapy, I'm going to teach you skills, now go do them. It does require more of a social intervention oftentimes, going back to that social model of disability. It's not just about the person and what they can do, it's about how do we modify the environment so that it supports them overall. Thinking through self-esteem, right? Those experiences of bullying, experiences of masking, not being connected to an autistic identity, like those can be very difficult. And sometimes creating a sense of identity development and esteem around those, valuing your disability identity instead of seeing it as something that makes you other, can be very critical to increasing mood and reducing anxiety. And then just like with any other kiddo, sleep, exercise, and eating habits are still relevant, and maybe more relevant in this population, given that they have a lot of restricted eating behaviors and a lot of sleep difficulties. And then certainly, like you can do, all these things can then be adapted to manualized cognitive behavioral therapy or other types of therapies, art therapy, play therapy, insight-oriented therapy, whatever it is that you use in your orientation. And I have this question. I know we don't have a ton of time for conversation, but I would be interested in the chat if you can think of certain features of CBT or other types of manualized programs that you can imagine being mismatched to a person with IDD that could be then addressed, right, through some of these adaptations. In addition to some of the visual supports, I would think more high level, especially the kids with more language, to honor cognitive strengths, use concrete examples with them, engage them in a teach back process. We use this a lot in the medical community. I think it's fairly common in mental health community too, but making sure that when you have, especially when you're sharing information about process or a new strategy that they're going to try, okay, let's take a break. We talked about this, like, what did you hear? Like, what are your next steps? Like, what do you understand that we're going to do? So that they're sharing back with, what are you going to do when you get home? So that you're making sure that they understand, and honoring that a lot of kids with disabilities, especially if they have a little bit of extra support, do have cognitive strengths that they can bring to treatment. Involving their interests, I think, is maybe more important in this population than in the general population, because it capitalizes on some of those kind of diagnostic features. It can get in your way or it can be a tool for you. And so involving interests and special interests and taking advantage of reliance on routines and things like that can often actually be a tool and an asset to therapeutic service, if you find a way to make it a facilitator as opposed to a barrier. So we like to adapt our materials, right? We create fillable comic strips. We do demonstrations with preferred figures. I have acted out more social interactions or like anxiety-provoking situations with My Little Pony figurines than I care to admit. There's a lot of awesome resources on YouTube and other kind of social media apps that are related specifically to mental health supports for kids and youth with intellectual and developmental disabilities. So you can find those. And I do think that a lot of kids like really enjoy making their own videos or recording their own voice notes. And that can oftentimes be a good support for them to use at home as opposed to something that's written. So again, I want to validate that communication in all its forms is not always at our best when we are upset. So we need to honor all communication options and think through how to provide communication supports with visuals or auditory supports or other types of supports when possible. They might rely a lot on connections between how they're feeling, where they're feeling it in their body, how that results in emotions, how that results in behavior. And that might need to be repeated more in this group than you might normally have to do. Include the whole care team. If you can help other members of the care team kind of model good strategies or share intervention supports or share the visuals across settings so that it's consistent for the kid, any of those kinds of kind of team-based approaches are going to be more helpful. And then thinking through also like what elements physically of our space could be getting in the way. Is there lighting that isn't preferred for the kid? Is there ambient noise? Is there anything that we could do to make them feel more comfortable? Do they like having something stretchy or scratchy that they can be holding during a therapeutic session? So considering the sensory preferences of the child as well. And then I have found that mind body supports inclusive yoga, inclusive meditation, inclusive mindfulness practice can be helpful. Again, this is highly like related to preference, just like it is in any other population. I find that these mindfulness apps have been especially a good fit for a lot of kids with disabilities. Our Strong Center offers free virtual yoga, inclusive yoga options for kids and parents. So I could connect you with that information if you would like to refer your family to that. And then some meditation strategies can also be helpful. And then certainly, just like with every other kid, I know you're all doing this already. I do think that making it clear that we're externalizing symptoms and that the thoughts and the feelings are not you is really important in this population. Again, kids are receiving messages that a lot of this might be related to their diagnosis. Their diagnosis is vilified a lot. A diagnosis can be used against them. And so making sure they understand that like anxiety and depression are also not the same as your autism is really important as well, because you can talk back to anxiety and you can talk back to depression and you cannot want those in your lives and also still cultivate a positive relationship with your autism or with your disability. And because disability identity is so important as a protective factor in this population, any reinforcement of the positive value of those experiences and perspectives is going to help with mental health. That's why I include it as the first one on just general best practice supports, supporting a kid through understanding their diagnosis. I don't make an assumption that everyone's going to align with their disability diagnosis, but exploring that with them could be helpful. Creating a sense of community, if they do identify, especially with their disability, connecting them to other autistic kids or other kids with Down syndrome through social support networks, through social media can be very helpful. Trauma-informed lens is always important, and understanding that trauma in this population is oftentimes like the things that might be little t trauma for a lot of people are big T trauma. For example, there's a lot of research to suggest that experiences of bullying in kids with autism is experienced like a full-blown big traumatic event that alters the trajectory of their mental health course over time, and adults will report this. So just considering that the things that they might be experiencing on a day-to-day basis could actually be causing trauma for them. And then we talked a lot about strengths focus approach and unconditional regard. As you're exploring a disability identity, as you're exploring what it means to be a mentally well person, a lot of people with disabilities will share how much negative feedback they get in so many situations, especially educational situations, sometimes in home situations. And so being a consistent provider who can provide unconditional regard can make a huge difference that might not always be apparent in the moment. I have some resources here. Some of that overlaps with some of the questions that are in this presentation. I will share some references here. You're going to have access to all of this, so I'm not going to spend a lot of time on it. And that takes us to 10 minutes, I think, of Q&A.
Yes, thank you so much for such an informative presentation. We do have a few minutes for answering questions that have come up, but I think you really you did a really great job of answering those that came in. But just a reminder for folks, if you have any questions, please feel free to submit those via the chat box, and we can certainly take a look at those. So a couple of questions that came in around caregivers of youth with IDD. So wondering if you have any suggestions for folks that are maybe feeling burnt out, that are feeling concerned and maybe anxious about the future of their child, right? And any specific suggestions that you might have, specific either to New York City was one that came in, but also New York State at large, or more so on a US wide, any sort of national supports that you might maybe suggest for caregivers.
Sure. So I know I'm Western New York. Our center's catchment area is west of the Hudson. So I know our Western New York context a little bit better than downstate, but I can speak to the fact that I know that there are parent groups downstate. I would contact the Westchester Institute of Human Development or the Rose F. Kennedy Center, who would have more connection with local support networks, but statewide. Parent to Parent of New York State is a fantastic organization. They have a lot of educational services for parents. They have a lot of support services for parents. They have a parent match program where you can kind of call up and state a concern, and they will match you with another parent of a child with a disability who shares your lived experience to be able to support you as someone who's walked that walk. And I have worked very extensively with the parent to parent group. They have offices like around the state, and I can't speak enough to their compassion and knowledge. And so that would be where I started. Oh, thank you for putting those links in there. Yeah, thank you, Gladys. The other thing I was going to say is Families Together program. They also, if you go to their website, they have important services like that as well.
Great, thank you. Question that just came in too. Are there any specific recommendations for female teens who tend to mask symptoms and difficulty for diagnosis?
Yeah, I did not have time to get into this. And I think Erica asked a question related to gender differences as well. I didn't have enough time today to get into this, but it is an incredibly important topic. So girls with autism tend to be at higher risk for mental health conditions, even compared to autistic boys. And so girls with autism tend to, especially those who have lower support needs, tend to go a long time and be better at kind of masking their symptoms for longer, so that by the time it's identified, either by themselves or by somebody else, they have gone a long time without a lot of support, which is incredibly taxing and emotionally taxing. Girls with autism also kind of interact socially. They have a lot more, just on average, desire to camouflage or mask in social situations, and tend to do a little bit better around camouflaging for short periods of time, but are not overall fully included. And so that desire is then compounded with like intermittent social rejection, which also can kind of exacerbate mental health concerns. So those are some of the differences that are really important to notice in autistic girls. And not all providers, I will say, are as well versed in how to specifically identify and diagnose autism in girls, especially teenage girls. So the awareness that this is a different experience, that girls might need more support and that they might have not received support in the past, is such an important starting point that you're already way ahead of the game, even considering this. I'm trying to remember the name. So there is the Empower. I'm going to put it in the, I have to put it in the chat because it's got a strange spelling. Empower Network. That's mediated, I think, out of one of the independent living centers, which focuses on girls with disabilities. It's not specific to autistic girls, but it is specific to girls with intellectual and developmental disabilities. And then I don't know where you're located, but I would kind of filter recommendations and referrals for providers who do a really good job working with girls and understanding autistic girls. We have a local in Rochester, New York. We have a provider, I'll put her name in here. She focuses on adult diagnosis, and she's very good with identifying diagnosis in women and trans women specifically. which is a completely different conversation as well, another heightened group at risk. And so I think that she does some telemedicine, so it might be worth reaching out to her practice. It's called Oaks Psychological Services. I spelled that wrong, but you know what it is, because I'm trying to type quickly. Yes, thank you. So those are the specific recommendations I can think of. I can also do a little bit more research to see if I can find other support for women.
Yeah, much appreciated. So let's see if we can squeeze in one more question. What do you recommend is helpful to address the fears and worries of IDD ASD clients whose parents are immigrants and may be deported?
Oh my gosh, this is such an awful conversation that we even have to have, to be honest. So I think that I would say honestly that the strategies for kids with IDD in this circumstance would be basically the same as what I think we need to do for all kids right now who have those concerns. I think we need to be really concrete. I think we need to explain whatever reassurances you have in a very concrete way. So if a parent is not at risk, explaining why in a very like simple sentences with visuals, something that's repeated over and over with the child to kind of like, even a kid without a disability, I think is going to have to hear this over and over and over again every day. And opportunities then to share questions and fears and concerns. Sorry?
No, go ahead. Sorry.
I was just going to say, if there is an actual risk to the parent, then I think that it's a balance between like creating some reassurance and then also making a plan for what is going to happen with this kiddo if this does come to pass. And in that case, identifying support from extended family, care teams, providers, anybody that you can leverage in their environment is going to be really important. Get everyone on the same page, make sure that the same message is being given to that child from everybody, and make sure everyone's on the same page about what is going to happen to this kiddo if something does happen to their parent.
Thank you. Appreciate it. So obviously very, very timely conversation, very informative. So on our very last slide, I do want to say a huge thank you to our presenter, Dr. Aurora, and to you, to our audience, for attending today's webinar. Our coordinator, Vanessa, has put in a link in the chat box for our survey. So again, we do ask that you take the time to fill it out. And we would really would appreciate it, as it does help to inform our future offerings. I do encourage you to visit our website, ctacny.org, to access past trainings as well as our resources, and to register for any upcoming webinars we have primarily in May. In 2 to 3 business days, you can also access the recording and the slides for this presentation, again, on our website, ctacny.org. And for those who are eligible for CEs, you will be receiving a detailed email within the next 2 to 3 business days as to how you can go about doing that. But if you have any questions or concerns, certainly please reach out to us here at CTAC. And you can do so at ctac.info@nyu.edu. I do see a lot of thank yous coming in. So again, thank you so much for you for joining us. Thank you to our presenter. And on behalf of CTAC and our presenter, thank you for joining us today, and have a great rest of your day.